all studying. So in terms of inclusion, we look on PCOT, we base on PCOT, whereby P is stand for population. So for this systematic review, our population is healthcare workers in different cadres that who are working in ANC, PNC, reproductive, maternal, and all of this about reproductive, maternal, and newborn health. So different cadres are included, such as nurses, midwife, obstetrician, and so on. So it's opposite for exclusion. So those who are not nurses or midwife, or the studies talk about midwife, but it's talk about the student is excluded in this study. For the set of intervention, this study is based on looking on reproductive, maternal, and newborn health studies based on a blended learning. And for the comparator, it will be face-to-face and outcome. Outcome of this study interested on looking the changing of knowledge, perceptions, skills, attitude, and also we are looking for health outcomes. And for the side of T, stand as a type of study. So we include all type of study except systematic review, literature review, and so on. But other studies, quantitative, qualitative, randomized control, non-randomized control, mixed method, all are included. After searching and exporting a study in the Covidence, to reviewer we begin for screening, title, and abstract. And when we have a conflict, maybe one reviewer said yes and another reviewer said no. So we need resolution. So the third reviewer come in and resolve this conflict. And after finishing this, this stage, we are moving to the full text screening. And we do as in a title and abstract. Two reviewer, they do full text screening, and the third reviewer come in for conflict. Here is a summary of is a preferred reporting prism for the study are included and doing a screening via Covidence. So in identification, in the early stage, we identify 4,920 studies. This we are driving from different databases, as I said before. After importing to the Covidence automatically remove the duplication, and the duplication it was about 1,403. After that, the study remaining and is undergo for full text. For title and abstract, it was 3,487. When we are doing title and screening abstract, we are removing some studies because they are not meeting the inclusion criteria. It was removing about 3,329, and then we are in a screening stage. Then we are having 158. This 158 is undergo for full test screening, and we are removing some. We are excluding some about Net 4 article due to several reasons. As we see that we remove some article with the reason like wrong setting, wrong outcome, wrong population. This excluded is based on our inclusion and exclusion criteria. And now we are included just 64 studies. For this is 64 studies, we are going to do a data extraction, and we are going to produce the result from these 64 studies. So here is some components that I will use for doing a data extraction. So when I'm doing a data extraction, I will extract a study from author name. I will use surname and year of publication, study country based on lower and middle income countries like Nigeria, India, Somalia, Tanzania, and so on. Also, we'll extract, we'll see the aims or objective of the study. Participant cadres, as I say, we need cadres like nurses, midwife, doctors, obstetrician, and so on. Number of participants, how many participants are included in that specific studies, study type, maybe randomized or and so on. Teaching approach, which teaching approach they use, whether they use blended learning or they use face-to-face learning or they combine these all two teaching methods. Outcome measures, we are looking for the studies for which outcome are looking for. Maybe they're looking for changing in knowledge, skills, perceptions, or health outcome. And the result also, we are including the result, and we will see the mean and standard deviation from that article that we are going to extract. Grading and analysis. For this systematic review, we are going to grade our study by using a mixed method appraisal tools. We are choosing this appraisal tool because it's designed to appraisal of systematic mixed methods, and also it's permit to appraisal the different methodological, and most is based on 5 study design, like quantitative, qualitative, randomized control trial, non-randomized control trial, and mixed method studies. Also, we will use Phillips return on investment model as a framework to determine or to evaluate the effectiveness of the blended learning and face-to-face toward the reproductive and maternal newborn health, which is lies on 5 levels. This model is same like Kirkpatrick, but this Roy model just adopted from Kirkpatrick and added the 1 level, because from the Kirkpatrick there are 4 levels, but for this level it's having 5 levels, and I suggested to you this one because it covers all the aspects which I need in my systematic review. Level 1, evaluating the participant reaction. Level 2, we're going to evaluate the changing of knowledge and skill during the training. Level 3, we are looking at the application and implementation after training when the healthcare workers going back to their workplace. And level 4, we are looking at the impact or results in terms of health outcome. Maybe it reduced maternal mortality, it increased quality of service, and so on. And level 5, we are looking about return of investment. We're gonna use this model, and we are going to see the cost benefit or cost analysis on these 2 training approaches, on blended learning and face-to-face. So here, this is my progress and the next step. Now I'm in the data extraction, so I'm starting to extract a little bit, but I'm not yet finishing. Then after data extraction, data analysis will follow, and then result is out, and reporting, writing, and publication also is follow after reporting, writing. Dissemination is ongoing process. We are disseminating, we are presenting everywhere. So thank you and welcome for you.
Thank you so much. These are very beautiful studies, and we look forward to actually receiving those results. Very well done, and you've kept time. Thank you so much, Zainab. And the next presenter is Umi Rahmat Ahmed Abubakar from LSTM, and the topic that is going to be presented is prevalence and risk factors of mental illness and domestic abuse among pregnant and 6-week postpartum women in sub-Saharan Africa. And this is a systematic review and a meta-analysis. Welcome. You have 20 minutes.
So good morning, everyone. My name is Umi Rahmat Abubakar. I'm a second-year PhD student, fully based in Liverpool, and today I would like to discuss about my systematic review inputs as part of my study objective. So my topic is prevalence and risk factors of mental illness and domestic abuse among pregnant and 6 weeks postpartum women in sub-Saharan Africa. So before I continue, I would like to acknowledge my supervisors, my supervisory team, which are Prof. Charles, Dr. Fiona, and Dr. Marian. And I would like to walk you through the following outline. So my background, my review objectives, the methodology, and the progress I've made so far, and the next steps I'm willing to take. So domestic abuse. What is domestic abuse? Domestic abuse is a form of incident or pattern of incidents, either of coercive, degrading, controlling behaviors, and also including sexual violence, either mostly from intimate partners or ex-partners, and this can also be from other members of the family or any carer. And it has significant implications for pregnant and postpartum women, because at this stage, a woman's life is associated with unique challenges and vulnerabilities. Vulnerabilities such as psychosocial factors. The pregnant woman, such as psychosocial factors. So WHO reported that 1 in 3 women experience either physical or sexual violence from an intimate partner or non-partner throughout their lifetime. And also, we're also going to look at the perinatal mental health. So mental health is a very important aspect during the perinatal period, and perinatal mental disorders are the most common complications of childbirth, affecting around 50% during the perinatal period. This could result in injury to the uterus, low birth weight, and other pregnancy-related complications. So understanding the background of mental illness and domestic abuse, it is very important to provide appropriate supports and interventions among these set of population. So the objectives I would like to cover for my review are to assess the prevalence and risk factors of mental illness, as well as domestic abuse among pregnant and 6 weeks postpartum women in sub-Saharan Africa, and then to explore the barriers and facilitators to routine screening of mental illness and domestic abuse during the ANC and PNC visits in sub-Saharan Africa, and then lastly to explore the interventions that have been used to prevent or manage mental illness or domestic abuse during ANC and PNC. So I would like to walk you through the methodology because it's a systematic review. It has various steps. So I first framed my questions based on the framework, based on the PICO framework. So the P stands for the population, which I'm going to include the pregnant and up to 6 weeks postpartum women. And then the I is for interventions, which includes the mental illness and domestic abuse. And then for the C is for comparator, and I have no comparator. And then for the O is my outcomes. So the outcomes I would like to yield at the end is the prevalence, the risk factors, the barriers and facilitators, and any interventions to manage or prevent these mental illness or domestic abuse during ANC and PNC visits. So in doing the systematic review, I needed to have inclusion and exclusion criteria. And for the inclusion, I'm including pregnant and up to 6 weeks postpartum women. I'm going to include papers that are written in English or would be able to be translated into English, and papers that discuss prevalence and risk factors of mental illness and domestic abuse within the context of the search phrase. And for the exclusion, we're going to exclude all sorts of studies that are done in other low and middle income countries other than sub-Saharan Africa. And then we're also going to exclude studies conducted in other settings other than healthcare facilities. And then we're going to exclude systematic reviews and all sorts of reviews. So this is the process I took in conducting, well, I will be taking in conducting my review. The first step was I developed a systematic review protocol, which I registered on Prospero, and then I proceeded with the search strategy, locating of the results, and screening of papers. And then the next was to extract data, assess study quality, and then finally analyze and interpret results. So this is just a little bit more detailed explanation of the process. So I identified several databases, such as PubMed, Global Health, Web of Science, and so on, and other search engines too. I yielded some search keywords, which I focused on mental illness as one, pregnant and postpartum women, and then sub-Saharan Africa, making 3. So I combined in the search, during the search, I combined all of these with addition to all the synonyms of these from other papers, and then I added them with the mesh terms or subject headings and the Boolean operators and or. So for the study selection and screening, the studies that were yielded from these databases, which were imported to EndNote, where I sorted them and then transferred them to Covidence. So I'm sure by now you all know Covidence from my previous colleagues. So immediately I transferred these papers. Duplicates will be automatically removed, and then it will move you to the next step, title and abstract screening, and then any eligible papers will be moved to full text screening. So for my data extraction, these are just some examples of what I intend in extracting from the papers that are eligible. So I will be extracting general information with information such as the study ID, the title of the study, the country of study, and then for the characteristics, I will look at the aim of the study, the methodology, such as the study settings and tools that were used in assessing these interventions. And then for the population description, I'm going to look at the total number of participants, the demographics, such as the age, the education status, the marital status, employment status, and etc. And for the obstetric characteristics, I will be looking at the stages. If it's during pregnancy, I will look at the stage, if it's first trimester maybe or second, and then for the postpartum, I'm going to indicate whether it was first week, second week, or anyone up to 6 weeks. So for the outcomes, I'm going to look at the prevalence, the risk factors, the barriers and facilitators, and the interventions that have been used to manage or prevent mental illness or domestic abuse in these settings, in these studies. So after the data extraction, I'm going to conduct a quality assessment of the papers using the MMAT by Hong et al. And these are examples of the examples of the items that are included in the quality appraisal tool. So example are there clear research questions? Do the collected data allow to address the research questions? Are the qualitative data collection methods adequate to address the research question? And are the findings adequately derived from the data? So these are just some examples, and there are more. There are 5 questions for each type of study design. So for my data analysis, after extracting data, I will be analyzing using the Max QDA. It's also ideal, it's an analysis software also ideal for mixed method studies. And the results of the analysis will be tabulated or displayed graphically using forest plots and so on. So also similarities and differences in study designs such as interventions, outcome measures, will all be highlighted and patterns of the data will be identified. So for my progress report and the next steps, this is the Prisma, and these are just what I've yielded from the search I did. So first, I've yielded, after the search from the databases, I've yielded 14,992 papers. And then after going through these screening processes, the title and abstract, duplicates removed, full text screening, I've ended up with 90 studies that are eligible for data extraction. And then for my timeline, yeah, the boxes colored in ash are the ones that I've already done. The one in red is the stage I am currently at, and the one in maroon are the next steps I'm willing to take. Thank you very much.
Thank you. I think we are doing very well on time. And session. Going to present on effectiveness health services in law administration.
Good morning, everyone. I think my work is a bit easier because and they've said most of the things I want to say. So I'm sure my presentation will be shorter than all of them. So this presentation is part of my PhD research. I'm a third-year PhD student in LSTM. My research I'm doing health services in Nigeria, but for this systematic review income countries. So I intend to follow this outline, give a brief background, objectives of the study, what such strategies I've used, eligibility criteria, and the others. So for the systematic review, I have completed data extraction, but I have not really gone far in analyzing the result, but I have just some preliminary results, at least about the quality of the papers and some of the information I got after the data extraction. So I will not dwell so much on this. Also, Zainab has helped us talk about it, but we do know that we still have a big problem with maternal mortality in Africa, and from all the presentations we had yesterday, we know that quality is really important. It is not just about having a healthcare worker or having the right environment. We also have to talk about the quality. And if you know the WHO health system building blocks, one of them key to that is the workforce. So whatever you have, it doesn't matter how beautiful your hospital is or whatever equipment you have, you really need good health workers that are grounded in what they're doing. So for my study, I will define what I mean by a skilled health personnel, and this is a definition by WHO, ICM, and UNICEF. So this definition, I think, came up, is just like an improvement on the definition of skilled birth attendants before. So for my study, I'm looking at competent maternal and newborn health professionals that have been educated and trained to international standards, which means if the health worker is in Kenya or the health worker is in Germany, they should be educated and trained in the same way. And they have been they are competent to provide and promote evidence-based and quality socio-culturally sensitive care. This is really important now because studies have shown that people sometimes refuse to go to facilities because of the type of care they against, because it's something against what they believe in or against their. In order to ensure a clean and positive childbirth for the her baby. So, like I said, the presence of skilled health personnel alone does not guarantee quality of services. So, apart from being competent, these skilled health personnel need also to be dedicated. That means they should go above and beyond, which means, just to give an example, 5 minutes to somebody's closing time, a woman is brought in with eclampsia. The person to take over is not around. So the life of that woman depends on whether this person is ready to spend 10 extra minutes to take care of her or go. So this is what the study is about, trying to look at what are the things, that actually lead to health workers being effective, these skilled health personnel. So I intend to look at studies that synthesize evidence that looked at knowledge and skills of skilled health personnel after an intervention, and those studies that assessed job satisfaction and retention of skilled health personnel. So I'm trying to answer the specific questions for this systematic review. What set of interventions improve knowledge and skills of skilled health personnel in reproductive health services in low-middle income countries, and what influences job satisfaction and retention of skilled health personnel? So the study protocol has been registered on Prospero, and that is the Prospero ID there. So just like my other colleagues, this is I use the PICO criteria in determining what type of studies I am going to include. So for the studies, I'm going to look at, for the population, looking at studies in low-middle income countries conducted on skilled health personnel working in maternity units. So, skilled health personnel, it depends on the country, different definition, but we know nurses, midwives, doctors, obstetricians. Here we have clinical officers. In Nigeria, we have community health workers. In other countries like India, they also have some other cadre, but I'm just going to include all cadre that are termed as skilled health personnel in the countries that they work. And the intervention I'm looking at is studies on reproductive health services, so maybe antenatal care, postnatal care, emergency obstetric care, breastfeeding, kangaroo mother care, family planning, and also looking at studies that have looked at supervision and job satisfaction of skilled health personnel. Studies I'm excluding are studies that are done in other parts of the world, not in low-middle income countries. Sometimes, you can have midwives working in, they say, a medical ward. So skilled health personnel, there could be skilled health personnel, but only those that work in the maternity unit, and studies that is done on adolescents. So what I'm comparing is I'm going to look at, for those studies, at pre and post tests, so like Kirkpatrick level 1 and 2, and some go further to Kirkpatrick level 3. After a time, they come back and still assess the health workers. So whatever intervention they're looking at, if something happens before the intervention, or it could be sometimes a comparison between two groups. So there are different studies that I have actually found out about this. So that's what I'm comparing. And the outcome I'm looking at is change in knowledge and skills. So for those studies that are talking about training, and then change in attitude, job satisfaction, and retention. So there are some studies that I have found already in the extracted data that talked about this. And the studies I'm going to look at will be all sorts of studies. So the qualitative studies and also quantitative studies. So randomized control trials, cross-sectional studies, scored studies, case control studies. But I've already excluded systematic reviews, literature review, expert opinions. They were not included in the study. So this is just a big picture. It's just for you to see. Don't worry yourself about it. This is just to show you the search strategy I used. So I used keywords and mesh terms in my search. And I looked at, I don't know why this is not really showing. It's showing here, but there are 4 columns there. I just look at different concepts. So the first concept I looked at was effectiveness of healthcare workers. The second one is the type of reproductive health intervention. The next one is the skilled health personnel. And then the third one is the low-middle income countries. So these are the keyword search terms that I used. And then this one is the medical subheadings or mesh terms that are used in the search. And I used the LSTM Discover tool to do the search, and also looked at databases, Global Health, CINAHL, Medline. I also looked at Google Scholar, some ebooks. I also searched the WHO website, FIGO, and ICM website. So for the data collection, I developed a data collection tool with different items. So this is just a summary of some of the things some of the information I collected. So on the paper, I collected the authors, the year of publication, the country, the research questions and objectives, what type of study design, the study participants, the type of maternal and newborn health intervention, what the study is comparing, if there is a comparison, and then the outcome measures, what the outcomes were. And then also, because I am looking at qualitative research, and there are a lot of studies on job satisfaction that are qualitative, so I also had a column for taking quotes for qualitative research. So I have that in the data I've extracted. So my colleagues have talked about this, but this is the tool that the mixed method appraisal tool. This is how the tool looks. So it's actually very easy, and if you're using Covidence, it's something that you can do side by side with your data collection. So as you collect data for the paper, immediately you finish, you can just go ahead and check the quality of the paper. So it saves you a lot of time. So this is the tool that we used. They've already talked about it and mentioned the first two screening questions. I think that's what I'll just mention. So for each paper, the first two questions there, the first one is, are there clear research questions in that paper? Do the collected data allow to address the research questions? So on the other side that you can't see, maybe after I finish, you will fix this. So there's a column on, there's a yes, there's a no, and a can't tell. So if when you're assessing any of the papers, if the question, these first two questions, if it is a no or can't tell, that means that paper cannot even be included in the systematic review. Before you now go to the type of study that paper is, the type of study done on that paper. So we have different, like there's a qualitative, there's a randomized control trial, down to the mixed method there. So for analysis and reporting, I use the same method with my colleagues. So we use the Prisma. I have a quality appraisal table. I have today, I'll just share with you what I have. Evidence summary table. And then subsequently, because of the results I've collected, there is a lot of studies. So you have, a lot of training. So you have mean values, you have standard deviation, some you have p-values. So later on we will conduct a meta-analysis on the data, and then from the qualitative data I will have a narrative synthesis which will address research question 2. So this still not very clear, but that is my Prisma. It's not quite clear, but I looked at papers published from 1st January 2000 to 31st December 2022. The search was completed on the 10th of March. All the results were exported to EndNote and then to Covidence, and just like my colleagues, title and abstract screening was done by 2 reviewers. And if there was any conflict, this was resolved by a 3rd reviewer. And after all that, we got 275 articles for full text screening. So I started with that Prisma is not very clear. I started with over 14,000 papers. When duplicates were removed, it came down to about 10,000. And then eventually, after the title and abstract screening, I came down to 275. So the full text screening was done by 2 reviewers, and conflict was also resolved by a 3rd reviewer. And eventually, we ended up with 45 papers for data extraction. So the data extraction itself was done by 2 reviewers independently. And if there's any conflict, if we had any conflict on what data to extract, we tried to resolve it on our own, the 2 through a consensus. And then anytime we could not reach a consensus, we brought in a 3rd reviewer to resolve that. So what I have found is most of the studies, out of the 45, 71% of them were done in Africa, 11% in Asia, and just about 4% in South America. So for the quality assessment, so I looked at all the quality and I tried to grade them into A to E based on, you know, that quality assessment tool that I have shared. So luckily most of the papers had at least a quality grade level B, and 17% of the papers, the quality is actually up to A. Only about 11% of them were of poor quality. So some of this table is missing there as well. So this is just an example of the table that I have. So I have this for all the 45 papers that I've extracted, but I just extracted these two to show, you know, the different types of studies. So for the first one is a qualitative study on, well, it's not showing there, but this is a qualitative study on job satisfaction that was done in Senegal. The second one is on emergency obstetric care done in South Africa. So there are other columns there that talks about, you know, the data that you have collected, what is the overall effect, all the costs. So this huge table there, but that is just a summary of the data we have collected. So the study is still ongoing as it is with my other colleagues, and I have gone a little bit further than them. So hopefully before the end of this month, meta-analysis will be ready, narrative synthesis around 13th of October, and finally we hope to have the final results chapter for this by 30th November. I don't know if my supervisor is happy with that, but I'm sure he will push me to do that. He's here, so hopefully we will have that by 30th November, and maybe sometime early next year we could have the paper ready for publication, and maybe in Tanzania next year when we come for KML we'll have the full results. All of us who might have the full result of our studies to present. So that is all I have to present. Thank you very much.
Thank you so much. Again, another very powerful study. So I know I didn't warn you in advance that we're going to have Q&A, but it's very clear from the program. So I would wish to invite the 4 presenters to come forward, and we'll take questions. And the way I would wish us to do it is perhaps we can ask the questions, quite a number of questions, and then we allow them to respond, and then we take another set of questions moving forward. So kindly, the 4 presenters, come forward. How we'll do it is you'll raise your hands. We'd expect you to raise your hands and ask the questions. Okay. So I would wish to anyone with questions, kindly. Okay, Dr. Lydia.
Thank you so much, Chair. My question goes to Maria on the quality adjusted coverage for ANC about your exclusion criteria, and I think also how I mentioned that you're going to exclude studies that are looking at teenage pregnancies, and for Maria, the ANC care for the teenagers. But from the most recent, for example, confidential inquiry into maternal death, we see that teenage moms are really having quite some proportion there, and pregnancy-related maternal deaths is an issue among pregnant teenagers. Why would you exclude them? Because it would be important for us to see studies that are looking into the antenatal care for pregnant teenage girls and what we are doing to prevent these maternal deaths.
Thank you. Any other?
Mr. Awa, on the issue of the skilled healthcare personnel, we know that you rightly say that our MMR, especially in this part of the world, is really still lagging. And of course, the issue of quality of care and the role of skilled health personnel really comes at the center of it. So my question is about the issue. We set up a skilled health personnel as certain competencies has been trained to a certain level as per national or global standards.
Okay, thank you so much. My question goes to Umi. I think I must really appreciate the entire team for the good presentations. I'm just trying to look at the topic, prevalence and risk factors of mental illness and domestic abuse among pregnant and 6 weeks postpartum women.
Is special care. So when we talk about pregnant women in general, we are talking about from 15 years to 49 years. So in that group, it includes the general population, all of them, rather than having only studies that are dealing with only a single population, a minority population, that is adolescent girls. So as we all know, they face a lot of challenges when they are pregnant. They delay, first of all, to access antenatal care services, and when they access, they are more likely to get inadequate services, and also they are more likely to get a lower quality of services. But then it doesn't give a clear general picture of antenatal care services, and as a result, we thought that for pregnant women.
Usually studies on adolescents is like a special category of patients. So I'm here, I'm actually looking at the screening on adolescents, but it's usually centered on mostly access. You know, how are these adolescents getting access to healthcare? How are the healthcare workers treating them? And I think that might be a systematic review on its own, because this is a really important component. So that's why I decided to exclude those studies that are focused on adolescents alone. And then, Brian, yes, I really agree with you with what you said, but I think this is what this systematic review is about, to really look at the quality of services that is provided by people that we term as skilled health personnel. But I assure you, most of the curriculum we have in Africa, I know in Kenya here, you've already updated your curriculum for midwifery. They have not done that in Nigeria yet, and there have been several studies. Even the midwifery curriculum in Nigeria is actually inadequate to meet international standards. Not to talk of the community health worker curriculum. Actually, they do have a junior community health extension worker. This is somebody that has been educated for 2 years in school. Is allowed to manage, you know, normal pregnancies, as long as there is a senior community health worker available, and anything they cannot handle, they should refer. So in Nigeria, they are termed as skilled health personnel. And if we take them out of our health system, definitely our health system will collapse, because they are the ones that we have. These are people that don't go anywhere. They are in Nigeria, nurses, doctors, and other healthcare that they move across the globe to other places. So this is one of the things I am going to look at. Initially, when I started the review, I had my first objective was to find out how does each country define skilled health personnel. But that one was eventually taken off. But we will have that in the discussion.
Thank you very much, Peter, for your comments. It's rather a comment than a question, and I will really look into that and see how I can adjust it. Yeah, thank you very much.
Thank you. Another round of questions? Yes. You have another mic.
Sorry, good morning. My question goes to Dr. Awa. I want to find out that when we are talking about skill-based attendance, I think you know our service delivery across the two different areas. That's my question.
Thank you. We have another question from Milimo.
Thank you so much. My name is Benson Milimo, and I have some 2 or 3 comments to Maria. With the foregoing discussion around excluding adolescents, it might be necessary to maybe now revisit your title so that it's not encompassing even adolescents whom we are excluding. Secondly, it goes to Zainabu, and that's about effectiveness of teaching. Now, if you look at your title, the way it's being reflected, at a glance, one gets some mix-up, and it's through keenness that then you reorganize your mind in terms of what you're talking about. So probably you may need to reorganize it so that it's looking at effectiveness of blended learning. The variable that you're looking at and we are comparing, it is the blended learning versus face-to-face. So those two need to follow each other. So that it's effectiveness of blended learning versus face-to-face, and it's for capacity strengthening and among who, where. So it should need to have that flow so that it makes a lot of sense. I know it is a bit wordy, which is okay, but communicating. So just reordering what you are studying, among who and where will bring a lot of order and a lot of ease in reading. And then I also have a comment on the third presenter, that is Umi. I don't know if it was just within me when looking at domestic abuse versus domestic abuse and mental illness. Throughout the presentation, I found those two variables apart. I looked for a connection, but I missed. So essentially, you need to be looking at each independently. You are picking domestic abuse and looking at its, risk factors, prevalence, etc. Then you look at, drug abuse. Again, you look at it independently. So you need to bring the joint. Where are they joined? Okay, I was looking for the hip. Or can we say joined at the hip? I was looking for the hip, but I didn't find. So please, you need to redefine that joint so that the two are related. So when you are looking at risk factors, they need to be encompassing, other than looking at each independently. And lastly, on HAOA, about effectiveness of skilled health providers, I think I want to second my earlier speaker. Remember, there have been changes in the terminology of definition. So as you do a skilled health provider, a skilled health provider, you need to look at skilled birth attendant so that you don't miss that aspect, but also look at other service providers who are providing the same skills in a different connotation, although not meeting the criteria of a skilled health provider. Remember, it was skilled birth attendant who are providing similar services we are looking for. Then skilled health provider providing the same services we are looking for. Then undefined, providing the same services that we are looking for. Thank you so much.
Thank you. One last one. Yes, right behind you. Yes.
Okay, thank you. My name is Mr. Nyamai, KMTC Kitui. Okay, what I'm saying is not a question, but I just want to say something in relation to something which has been mentioned by somebody in terms of the key definition of a skilled birth attendant or a skilled professional. Actually, when you look at our system, like in Kenya, the lowest level the nurse goes is at dispensary level. But between the dispensary and the family, we don't have somebody. So there is a gap. So I think it's very important to embrace those people we are calling community health assistants or community health workers who will fill that gap between the dispensary and the family. It's very important. And going forward, I think it's important we include a component on midwifery in their curriculum so that we capacity build them. Because the nurses, there is a lot of exodus. Somebody mentioned about many nurses going abroad. Because of that, then once a nurse is trained and then a gap is left. Thank you.
So the question. So can we compare skilled health personnel? The question you asked about, like skilled health personnel in Nigeria, can we compare them to the ones in other developed countries? I would say yes and no. As you know, I'm sure even from your own perspective, in your position as the Director of Public Health, it is the people that are really good, those that have really been trained and are good, that mostly move across the globe to go and work elsewhere as skilled health personnel. But which means people can actually, even in Africa, people can be trained to that international competence to be recognized as skilled health personnel. So we may be able to compare on some level, but then on a lot of levels, when we look at some kind of healthcare workers we have on our own side, like we have community health workers here, they have clinical officers, and also in some East African countries, we may not be able to have a place to place them as skilled health personnel, because really strictly the definition from WHO and partners does not really include this cadre, but I think that is what he was trying to talk about. So I will take your question here too. So like in Nigeria, community health workers are not the same as in Kenya. In Nigeria, they have a part of their curriculum involves midwifery, and that is mostly what they do. So they have a big chunk of their curriculum that is midwifery, and they get a lot of practicals from that. So during their training, they go to hospitals, usually government hospitals, and they learn on the job. The only problem, personally, I feel with the community health worker training in Nigeria is they are taught too many things. They teach them everything from circumcision to managing childhood illnesses, so maybe if we tailor it to just, let's say, there may be reproductive health, this group will have reproductive health, this one will have pediatrics or something like that, they might be able to fit in better. But the way our health system is in Nigeria, I don't know, maybe you were not here yesterday, we have the local government area that takes care of the primary health care. And in the primary health care, it is the community health workers that you find. Even if you find a nurse or a midwife, mostly the head of that primary health care would be a community health worker. And they are 10 times more than the other health workers that we have in Nigeria. So I understand the gap you're talking about. We, right now, recently, I think maybe in the last 2 years or 3 years, the Nursing and Midwifery Council of Nigeria, because of the way nurses are leaving Nigeria, we were with Lydia, you remember, with the registrar of the Nursing and Midwifery Council, and he told us last year 14,000 nurses left Nigeria. 14,000. So they created another cadre now that they are teaching. They call them community midwives. So they teach them for only 2 years, hoping that nobody will come and poach them. But he was telling us Egypt has started collecting them. So these are just issues. Yes. So these are issues we have. There is a lot of gap between really how to retain those people that are actually skilled health personnel, those that have been trained as skilled health personnel in our own countries, and then also what sort of care, how much are you going to teach them? So if you decide you want to improve the curriculum of a community health worker to that of a midwife, then what are you doing? Are they now going to come out as midwives or community health workers? So I think there's a lot of complication, and I think it addresses some of the, part of your question too. So all the studies that I've collected, I'm going to address all the things that are being raised. Because I realized, like in India, I have some studies from India, I had to go and look for definition of what they call lady health workers. There are so many studies on lady health workers, and I actually thought they were community health workers. But when I went and looked at it, these are just young girls trained for 6 months to do certain things, and they are either taken to your hospital or to community. So I just hope that at the end of the day, we should be able to pull together everything about, well, maybe we might come up with our own definition of what a skilled health personnel is in Africa, possibly at the end of the systematic review. Thank you.
Thank you. I would like to thank you, Dr. Benson, for your comments. I will rearrange my title, but I will discuss it with my supervisor, because my broad objective of this PhD is to do a comparison on effectiveness of blended learning and face-to-face learning approach. So this systematic review is one among the specific objective of the broad objective for my PhD work. So thank you so much. I'll work on it.
Thank you.
Thank you, Benson, for the question. Yes, I agree that they are not the same, but at the end they do have relationship. Where you find domestic abuse or violence, you do find mental illness. But then I did not capture it there, but I do have it in the back of my mind that at the end I'm going to look at the relationship between them. So maybe, I don't know, maybe I should include in the objectives. I already have certain objectives, broad objectives already. That's why I did not include it in the written part. Yeah, but I was intending in looking at the relationship at the end after collecting, because at first I was going to do 2 different systematic reviews, because I'm going to look at all of these aspects, risk factors, prevalence on differently for both. Yeah, so that's why I'm intending on linking them up at the end after collecting the data from the papers. Thank you.
Once again, thank you, Benson, for your comment. I think when we look at women of reproductive age, starts from 15 years to 49 years. So completely excluding any study that has included women who are 15 years would be an injustice. And at the same time, including studies that have just focused on teenage or adolescent pregnant women would again be another systematic review altogether, and at the same time it would skew the results towards a certain extreme end. So that's why we just mentioned the population to be pregnant women, that is women of reproductive age who are pregnant, starting from 15 to 49 years. But we're excluding studies that are specifically focusing on adolescents for reasons that I've just mentioned. Thank you. So for that reason, I cannot change my
Thank you so much. Actually, very lively discussion, and I feel sad. We wish we had more time, but of course time is far much spent. So we can continue this out there. So I would like now to welcome Lucy to give us direction on what we need to do next. Thank you so much. I thank the presenters. I think you can sit. Thank you.
Okay, thank you very much. Very interesting, very engaging, very informative sessions. I think we can do better in terms of the club, isn't it? Yes. So, no, wait. Wait. So, Ryle, can you lead us for, I ambush people, sorry. So, can you, Ryle will give us the formula that we can do so that we can appreciate them better. They are doing a good job.
Lucy, as they do that, I'm a little bit worried. Why is the man gender?
That was one of the questions. Yeah, it's not for the Kenyans, they know what I mean. So, but yeah, I think even you know, I was just thinking also most of the times I interact with, we have quite a number of when you go to a class, we have quite a number of this gender imbalance. So it's something to note and to really bring up, because unless we have an equal world, there is nothing that we really can have. Thank you. Ryan.
Okay. All right, so let's stand up and appreciate the presenters. Yeah, I think we'll give them a 5 factorial. I think that should work for them. So get ready, warm your hands. Let's go. Sorry. Okay. 1, 2, 3, start.
That's how we say, well done, well done. I have a niece. Keep it up, keep it up. A very good job. Okay, great. So now we are coming to the end of our morning session. Thank you very much for managing time well, but we have a few minutes to our tea break. I want us to do 2 things. Look at page 7 of the booklet that you have, and kindly, those that can immediately, let's engage on Twitter. Because the good work that is here, let's shout about it and tell the world what we are doing, then we are not able to do. So please do post their photos around and let people know what is happening for now and for future. That's number 1. The second thing, I take cognizance of that there's some people who came in after introductions. I kindly request, if you did not have a chance to introduce yourself, just stand up and you'll let us know of your name, designation and the institution that you are coming from. Let's do that quickly in a minute. If you did not introduce yourself, kindly stand up. Onesmus will give you a mic.
Good morning.
Good morning.
Millicent Kabilo, KMTC Nairobi, midwifery educator.
Thank you.
Good morning. Frederick Wekesa Wanyonyi, Head of Nursing Department, KMTC Bungoma.
Good morning. Dr. Lucy Waweru from KMTC Atomic Registrar.
Good morning all. My name is Faith Mudama, Head of Nursing Department, Nyeri Campus, KMTC.
Good morning, Dr. John Aswani, Lecturer, Department of Clinical Medicine, Nairobi Campus, KMTC.
Good morning, Professor Lucy Gitonga, Dean, School of Nursing and Public Health, Chuka University. I'm a midwife.
Good morning, Benson Milimo, Head Midwifery Department, Moi University, Kenya, and Midwifery Educator. Thank you.
Good morning, Rose Mbogo, MTC Msambweni Campus. I'm the HOD nursing.
Good morning. My name is Zachary Nyaga, HOD nursing, KMTC Morana. Thank you.
Good morning. I'm Dr. Salma Abdul Mahmoud, obstetrician and gynecologist from State University of Zanzibar.
Thank you very much. More time to interact. Okay, so the final announcement that I would like to make is that I kindly request that immediately after this, we shall walk down to the front of the hotel at the staircase. I would like us to take some quick photos. I'm advised that this should take 10 minutes. So please, 10 minutes to take the photos. So we still, if we can do that, we'll be in time for our tea. So let's all head there. And Meshach there, the gentleman, you listen to him. He'll give you instructions so that we can quickly take these photos and be back for our next session. And our next session starts exactly as per the program. I do not have it here, but we should be back here. Thank you very much, and thank you for your attention.